Respected chairpersons, very good morning, all the delegates. And first and foremost, I thank the entire scientific committee for giving me this opportunity. Coming to menopause and diabetes, the transition is the most welcome phenomena in life. The continuum of women's life can be divided into several life stages, each characterized by certain features, accompanied by considerable hormonal changes, divided into infancy, childhood, puberty,
Can
reproductive
we
age,
have ma'am slides, please? On this.
climatic period, and elderly years, in addition to pregnancy and delivery. We'll see the interplay of menopause and diabetes. Menopause is nothing but a normal part of aging, but hormonal changes negatively impact the diabetes control. That is the problem. Here you can see such a lot of women, they have undergone menopause very efficiently along with diabetes also. So how to go about, if you see the common health issues with menopause, we do have more of hormonal changes, heart disease and cardiovascular health, breast health and breast cancer, osteoporosis and bone health, mental health and emotional well-being, and there's weight variability and metabolism. So how to deal with menopause challenges? Menopause has its own burden and have different associated medical conditions and comorbidity. Mainly, the menopause is characterized by substantial decline in estrogen production. The androgen also declines, but at a lower rate, though, so there is a relative androgen excess. These subsequent hormonal alterations linked with insulin resistance, central adipose tissue deposition, and a decrease in lean mass. The incidence, because of all this, the incidence of diabetes dramatically increases when the women come to the postmenopausal period. Here you can see that there is estrogen deficiency with a relative androgen excess leading to body compositional changes like increased total body mass, visceral abdominal mass, subcutaneous abdominal tissue, and decreased peripheral fat with ectopic fat storage in the liver, skeletal muscle, reduced total and peripheral lean body mass. All this happens during menopause. If you take estrogen, it has a many multiple actions like in the brain, it controls the energy balance. If there is deficiency, of course, there occurs insulin resistance and obesity. And in the adipose tissue health, again, the estrogen deficiency causes obesity, adipose inflammation, altered secretory profile, and it is also associated with the beta cell function and survival. So, when there is deficiency, there occurs beta cell dysfunction leading to type 2 diabetes. And in the liver, it is concerned with the insulin sensitivity and lipid homeostasis. And deficiency, of course, leads to insulin resistance and fatty liver. And in the muscle, there is insulin sensitivity, and it's the major reason for energy homeostasis. And in deficiency causes insulin resistance and impaired glucose homeostasis. And it is concerned with the macrophage polarization. Deficiency leads to inflammation, adiposity, atherosclerosis. So all these detrimental effects of estrogen deficiency affects the metabolism. And what is the risk of type 2 diabetes after menopause? At the menopause, it's in aging where there is decreased physical activity, increased comorbidities, increased depression, and all this leads to decreased muscle mass, decreased energy expenditure with increased body weight, and more of insulin resistance. And again, the estrogen decline, on the other hand, it causes changes in insulin action, reducing the muscle mass, increasing the triglyceride in muscle and liver, leading to chronic inflammation, reducing the sex hormone binding globulin, and increasing the androgen to estrogen ratio, decreases the insulin signaling through endoplasmic reticulum alpha activation, all of course leading to insulin resistance. And changes in the beta cell function is also affected. There is change in the insulin secretion and degradation. There is increased beta cell apoptosis with decreased insulin secretion, increased hepatic insulin degradation, all leading to the failure of pancreas to meet the increased insulin need. So, net result of all this is more of type 2 diabetes after menopause, with more of cardiovascular health being affected. And in type 1, if you see, the diabetes experience menopause much earlier than those without diabetes, And it also depends on the duration of diabetes, and both worsen with each other. And if you take the effect of diabetes on ovarian aging, there is premenopausal adiposity or weight changes. This leads to late onset diabetes and also late menopause. On the other hand, the diabetes affects the causes releases in type 1 autoantibodies and causes autoimmune destruction of the ovarian tissue, and in the endothelium there is dysfunction leading to cardiovascular morbidity and microvascular complications. And the uncontrolled diabetes again causes early depletion of ovarian follicles, and all these affecting the ovarian aging leading to early menopause. Either of this can occur. And the menopausal related central fat distribution, this again increases the pro-inflammatory cytokines, increases the vistapin, decreases the adiponectin, and increases the free fatty acids, all resulting in increased insulin resistance, of course. That will lead to hyperglycemia, dyslipidemia, and hypertension. So, menopause is associated with all these obesity, dyslipidemia, hypertension, glucose intolerance, diabetes, all are components of metabolic syndrome, which is all due to insulin resistance. And if you see the metabolic changes, of course, they are all related to the insulin action. There is altered sex hormone concentration, relative hyperandrogenemia, and decreasing sex hormone binding globulin, reduced insulin signaling through reduced activation of the estrogen receptor alpha, and there is, of course, increased visceral obesity more in women, and increased production of free fatty acid, which are converted to triglyceride in the muscle and liver especially, and all leads to chronic inflammation. And if you see the chronic in insulin secretion and degradation, there is more of apoptosis of the pancreatic beta cells and augmented hepatic insulin degradation, both leading to insulin deficiency. And there is again early menopause and premature ovarian insufficiency leading to the risk of type 2 diabetes development after menopause, which could be influenced by the duration of exposure to these sex hormones. And there is a shorter reproductive lifespan, which again increases the incidence of type 2 diabetes. The premature ovarian insufficiency and early menopause are again associated with the increased risk of type 2 diabetes in later life. And women with this premature ovarian insufficiency showed an increased risk of type 2, 32%. How they have found is those who underwent this surgical hysterectomy who had menopause could also result in higher risk of type 2 diabetes. Of course, if you see in the most menopausal women, they had a more incidence of diabetes because of the increased lifespan. And women with type 1 may go through menopause earlier. And there is a conflicting data that one study suggesting 6 fewer fertile years in type 1. And the autoimmune premature ovarian failure in women with type 1, there is increased abdominal fat, decreased lean body mass associated with menopause because of increased insulin resistance. And women with type 2 are at increased risk of endometrial and breast cancer. And there is more of osteoporosis, you all know. The lower bone mineral density is common in type 1 compared with women without diabetes. But on the other hand, in contrast, type 2, they have higher bone mineral density if they are not on glitazones. Despite this bone mineral density, there are fractures more common, more falls, changes in bone structure, vascular changes, and increased risk of foot fractures with exercise. And how to manage? Of course, lifestyle adjustment is the first and foremost. They need to shift the diet to focus on anti-inflammatory diets rich in fiber and complex carbohydrates like beans, quinoa, and whole grains to prevent the sharp glucose spikes. And we need to, of course, adjust all the medications, diabetic medications. Menopause and diabetes, they are associated with more of weight gain, increased insulin resistance, more of visceral fat, all increasing the cardiovascular risk. So you need to constantly watch and adjust the medications. And coming to the hormonal therapy, it depends on the cardiovascular risk. And of course, these women are more prone to infection. You need to manage the infection efficiently. And they do have sleep disturbances due to the menopausal symptoms. And the important thing is they need to undergo this strength training. That is very important than just doing the aerobic exercises. And stress management is very important in them by doing yoga and meditation. So, of course, you need adequate glycemic control, weight reduction. All these helps in reducing the cardiovascular risk, osteoporosis, and sarcopenia. And women with diabetes and menopause should follow the same guidelines that applies to all patients, with more concentrating on lifestyle modifications, adopting a healthy diet and exercising regularly. But this one size doesn't fit all. You need to see individually for the woman which fits her, like medical nutrition therapy, exercise, or altering the OHs or insulin. All depends on that particular woman. It is individualized. The main thing is you need to give her psychological support. Coming to hormonal replacement, this improves the insulin sensitivity and gives a very good glycemic control. Of course, we have the transdermal patches and gels, often preferred for these diabetic patients, as they are lower risk of there are lower risk of blood clots and compared to the oral pills. And of course, you have to adjust the medications according to the blood sugar variability. When this both coexist, that is the diabetes and menopause, you have to give more preference for cardiovascular risk satisfaction according to the age, hypertension, obesity, smoking, dyslipidemia, prevalent CVD, target organ damage, and the duration of diabetes. And as I said, lifestyle intervention is very important. Reduce the body weight and go for healthy diet rich in MUFA, PUFA, and nuts and seeds. If there is calcium vitamin deficiencies, if there is inadequate, insufficient in the diet, you have to supplement from outside. Alcohol, it has to be in moderation or stop, and smoking cessation. They need to do more than 150 minutes per week also, but mainly insist on resistance training. As far as diabetes medications are concerned, if they have heart failure, CKD, obesity, or high risk for CVD, better prefer the GLP-1 receptor agonists or SGLT2 inhibitors, and better avoid the glitazones and canagliflozin because they have the more risk of osteoporosis. And always remember hypoglycemia that has to be prevented. And regarding the hormonal therapy, oral estrogen that is during the perimenopausal period or recently postmenopausal women with diabetes duration less than 10 years and no cardiovascular risk. You can go for transdermal beta estradiol patches, or in perimenopausal women or recent postmenopausal with less than 3 cardiovascular risk factors or no target organ damage, you can prefer this hormone therapy. Of course, you can even use micronized progesterone or dehydrogesterone or low dose norethistone acetate or transdermal norethistone acetate for endometrial protection. And again, here you have to avoid hormonal therapy if they have prevalent cardiovascular disease or target organ damage or more than 3 cardiovascular risk factors, and also in type 1 more than 20 years duration. How do these hormonal therapy help in women with diabetes and menopause? Of course, it has a very good impact on the glucose control by reducing the insulin resistance, lowers the fasting glucose level compared to no hormonal replacement, and 30% reduction in the incidence of diabetes in women taking this hormonal therapy versus not taking. And of course, we need to avoid in those with cardiovascular diseases, and if they have risk of breast cancer or risk for, and of course, this helps in osteoporosis and in the severity of vasomotor symptoms. Thank you.